Thanks a lot. Couldn't be more pleased to have my good friend Claudio introduce me. And that experience with the SSAT Traveling Fellowship was a transformative experience for me to go over to Europe and see how everyone else does the anastomosis, the rest of the operation. And that's where I started to build a lot of bridges and relationships over time. And this is a great friendship and collaboration that we have with Verona. And I think it has a lot to do with what I'm going to talk about today, because I was fairly early in my career at that point and not trying to find my way at that point, and particularly academically. So come around to the fact that I know a lot about pancreatic fistula these days, and I wanted to share about a decade's worth of work with you on that. So we've come a long way, baby. Pancreas fistula, why are we here? Why are there a lot of people in this room? Well, it's a really important topic for pancreas surgeons. It's our Achilles heel. We all know it's highly morbid and frequently lethal. Here you see what's basically a complete gap in an anastomosis between the pancreas and the bowel, and that's going to lead to what we would call a grade C fistula and perhaps even death. In America, we have something called the critical portion of the procedure, and that's really where the attending is supposed to be there because it's the hardest, most important part. We call this what did we do because we have to say that we're there to bill for the case legally and financially, but really its essence is that this is the most important part of the procedure. So let's take you back to the beginning, and here's Whipple and his first case. Well, I bet many of you don't know who the guy on the right is. That's Clinton Mullins, who is his resident or his assistant, who had been doing a lot of lab work. It took about 10 years for Whipple to get to the point of actually doing the Whipple procedure and launching that in the 1930s, but he had been doing work for a while, and he had an army of people helping him in the dog labs. Well, it turns out that the first successful Whipple actually died of a pancreatic fistula. And it was his assistant who realized this, and largely attributed to the fact that there were degradable sutures used for the anastomosis, and they basically rotted out. They were able to look at that on autopsy and show that, and that probably gave you something like this to lead to the fistula. Well, here's where I started in the 1990s when I was a medical student, and this is what I actually, in a perverse way, was attracted to surgery for. And it was this kind of abdomen and all these people in the ICU, and I thought, wow, the belly is pretty amazing. I mean, look at this. This is crazy what we're doing to people, and how can they sustain this stuff, and all these open wounds and reed takebacks and all the likes. And for whatever reason, I was attracted to this intellectually to think that this is really bad and we got to do something better about it. And so that started my journey into the pancreas over time. Well, what's behind this title? It's really a declaration of progress. I don't know about blues songs like you do, Claudio, but I do know this, and that is this is an ad campaign from America in the 1970s where the cigarette company was trying to make it fashionable for women to catch up to the men and smoke cigarettes and look cool, and you've made it, baby. And that's basically where this came from. So I'd like to say is that I'm going to try and present a lot of progress that we've made in this recently. So I'm going to fast forward from 1934 through a lot of decades of hard work in the operating room to get the operation better, but really the definition of a fistula was problematic. There were, as Claudio pointed out in a great paper, there were 26 different definitions based on people's institutions, the rooms that they, or the institutions they came from, their own thought of what a fistula was. And then the idea of there being something called a clinical condition or a clinically relevant fistula was started by Andy Lowy when he was at MD Anderson. But Claudio really brought the band together and was able to bring a unifying definition for us through a consensus process. And this is one of the most successful papers that we have in pancreatic surgery, and maybe all of surgery in the last decade. So it was the IESGPF that brought that bedrock for us. And I was very fortunate to be able to take that definition and apply it really for the first time to a clinical set to actually validate it and say, hey, what these guys, these wise men thought up was actually valuable and valid. And we were able to show that, and now the ISGPF definition is the standard. Well, we're actually getting to the point of revising this and actually improving it, which you'll find out soon. But it's really been valuable. Here it is. Basically, there are 2 categories and 3 grades. The first is the biochemical category, which is basically what I'll call sweat off the pancreas. It's an amylase level in a drain, but it has no impact on the patient at all. We have some controversy over what this is really and if it's valuable to even talk about it. We also then have the clinically relevant group. This is what we're all interested in, and this has the B and C grades. Now, C is really the most severe, and it's dictated by having to reoperate, having a septic patient with organ failure, or having a death on occurrence of the fistula. And if you want to learn how to use this or apply it to your practice, go to the Pancreas Club web calculator, and you'll be able to put your patient's characteristics in, and it'll spit back out to you where they stand in terms of this. So, what's the real deal around the world? I always thought when I was growing up that this was a 15% rate, and it was a fixed number biologically. I mean, every paper said it was 15%. Well, it's pretty close. I was able to gather together a group of about what's now about 5,500 cases of Whipple's over the last decade or so, but this group was 4,000. So this gives you a real flavor from around the world that your clinically relevant fistula rate really settles in around 10 to 11%. And if you want to look at the grading of it, most of that is a grade B, with about 2% of all your cases being these tragic grade C fistulas. Now, we think that awareness of this begins preoperatively, but is it completely said and done that you can predict something like this in a preoperative setting? I don't think so. I think that it begins there, but if you determine something preoperatively, it rarely disqualifies a patient who needs a resection, and it rarely alters what you can actually do in the postoperative course of the care. And rarely do we actually apply it in a way that makes an effect on the patient. So we actually believe that there's a lot to be learned in the operating room, such as the quality of your anastomosis when you're making it. You know what you did and how you did it. You get a more accurate assessment of the gland features than you might on preoperative imaging. You know the physiologic state of your patient, and you know the prophylactic treatments that are at your disposal. This also can influence your postoperative management at the time you're doing your anastomosis in the operating room, and we hope that this would help with the research standardization as well. So what do you think influences pancreatic fistula? We had this nice survey of 900 surgeons around the world, and I hope many of you contributed to it, and I thank you for that. We asked, what do you think contributes to a fistula? What do people think? So by and large, gland characteristics dominate, some patient factors, some intraoperative factors, but then a paucity of people actually think that your institution matters, or even what you do with these mitigation strategies. I think people feel they don't affect the fistula happening, but they may affect their burden. Most surgeons selected that there were numerous factors in play. We think this is a multimodal process, and the most important factor that keeps coming out is the gland. It's all about the pancreas, as we know, so 2/3 of the people thought that. More interestingly here, if you had surpassed the learning curve, you would think that gland characteristics are more important, and that intraoperative factors and perioperative strategies are less important to fistula outcomes. If you're in the upper quartile of actual volume, and that's per year, that's actually doing 25 a year or more in the world, you would think that gland characteristics are important and that patient factors are less important. There was clearly a global variation on what people thought around the zones of the world, and at that point, about 2 years ago when we launched this, about a quarter of the world had understood or seen or realized the fistula risk score that I'm going to take you through today. Well, that goes back to the ISGPF, and having this definition and then validating it allowed us to then start to hone in on what are the risk factors for this. So we had a very early investigation in this in the World Journal of Surgery, and this basically came down to 4 core factors. Some of this was obvious already, but putting it all together, we found some other things. So soft pancreas parenchyma, certain high-risk pathology, which is anything but pancreas cancer or pancreatitis. small ducts, and at that point we had a dichotomized 3 millimeter or less, and excessive blood loss being a huge amount over a liter. Interestingly, we found, and we have never found ever, any risk predictors for biochemical grade A fistula. It's just a meaningless thing, and we can't even say when it's going to happen. So we should probably forget about using it. When you put these 4 factors together, you can make a computation that makes a very simple, easy to remember 10-point risk scale, and that's called the fistula risk score. And it's been prospectively developed and then internally validated, then externally validated. And basically you have the 4 elements, and based on their power, basically, or influence, you can make this scale. And you'll see that you get the most points actually for the 1 millimeter duct and for a large blood loss, actually. So that's the genesis of that. Well, let's take a look. If you went 0 to 10 across that scale, what's going to happen? If you're at the 0, that means no risk factors accrued. You're going to have what we call negligible risk. And we wanted to say no risk when we wrote the paper, but someone told us to make it negligible because something could happen. Well, lo and behold, when we looked at the big group, there was 1 or 2 fistulas that happened in that group, but it really shouldn't. But you see the escalation here across there, and I think if you take the big picture of this, you'll see a graded stepwise progression across a couple of groups. So we were actually able to collate these into 4 distinct groups. The group on the right, the 7, 8, 9, 10, is the high risk, and that's going to top out somewhere around 30% in bigger series. Well, what happens when you go across this scale? Well, this shows your risk, your chance of having a clinically relevant fistula. And it goes from 0 to about 30% across there. But along with it travels all the debris with it. And that includes overall complications, duration of stay, and the readmissions. And they go up along with that scale as well. This shows some other interesting aspects about this. If you look at this group of 5,000 patients, your mean score for all patients would be somewhere in the 3.5 range. Your median is 4. The most common risk score is a 3, kind of on the lower end of the 10. And we had a range of 0 to 10, as you would expect. But on the other side of the scale here, on the distribution column there, this tells you where they are. Most of your fistulas are going to be in this moderate zone. But there is the 10% or so that is negligible, should never happen basically, and then you got this 10% that's really high risk that really are the ones that we're sweating on. You're in the operation, you say, wow, what am I going to do about this? The FRS has been validated a lot over the last 5 years. We did it ourselves in a multi-institutional fashion, then we took it multinational. We have, I think, the most extensive paper on this came out at the end of the last year in Annals of Surgery. Even at this meeting, there's going to be a paper about a multinational group that includes non-academic surgeons. That's on Saturday. It's been validated in cases where patients or surgeons don't put their drains, and in laparoscopic cases as well. This is a picture that I sort of call like the Affymetrix gene chip of pancreatic fistula. It's basically just to show you the variation in risk that we all assume. I was really fascinated. What does Sloan Kettering, a cancer hospital, have for risk compared to mine, or maybe another place like Verona that's very high on cystic disease? So we wanted to investigate this. So this will show that if you look across institutions, we all take on a different profile of risk. The purples being the the high group, and you see some of these people have very, very low rates of low risk cases. So there's a variation across. This would be the same picture if you looked at surgeons. We had 55 surgeons in here, and look at this. Some of the surgeons in the series only had low risk scenarios. Others, one had a predominantly high risk, and then there's this huge variation as well. We're also able to look now not at the risk that you take on, but let's look at the actual occurrence around variation around the world. So on the left hand is the institutions in the series, and you see that some are humming at the 2 to 3% rate for clinically relevant fistulas, others 28%. Okay, these are reputable people and big institutions, and they do good surgery. but there's a real difference here. The one on the right shows the surgeons in that group, and what a huge splay we have there. Now, however, you'd think that, well, if you have risk, well, then that should equate to the actual outcome. Well, that's not necessarily the case. This is, you would expect to see on these graphs that there would be a straight line from the bottom up to the right top. But instead, it looks like buckshot. And it actually indicates to you that although we have an idea what this risk is, it does not necessarily correlate well completely. What do people do about mitigation strategies? Well, this is the answer to that last scenario there. We have the ability to impact the risk, and we do that with what I call mitigation strategies to try and manage that risk. So if you look at around the world, intraoperative drains are almost always placed 3/4 of the time. Octreotide is never used half the time, selectively on up the other half. Stents are a mixed bag. You're equally as likely to always do it or never do it. And sealants are almost never used, but some people use it on every case. The number of drains we use is generally 2. Blake drains are the most popular, but we have a variety of types, including Penrose's. And if you do use a stent, you could do an internal, an external, or equally either at some cases. And interestingly, although there's a lot of talk about pancreatic gastrostomy in the literature, it's actually rarely used. And in this case, with a couple institutions who use it liberally, we only had a 3.7% rate of that. Now, we took this and we took that risk stew and the outcomes, and we tried to figure out, well, how does a surgeon or an institution perform with this? And you have to put in these moving parts of the fistula mitigation strategies and your institutional volume and your experience and all this kind of stuff. So we came up with what ends up being a complex statistical model, but it's very similar to what the ACS-NSQIP does in terms of developing O to E ratios and their reports back for quality. So it's the same process. And what we were able to see here is that you clearly have institutions who perform better in the face of risk than others do. And to show you here, we can develop a scorecard that way, where if you look at just to simplify it, the greens and the reds mean how's an institution doing compared to the risk that they take on. So they can jockey up and down based on that. So positive numbers are in green. That means you're doing better than you should. Red numbers are worse. You're falling back. So we can also apply this to surgeons. Here's the 50-some surgeons, and you can see that there are a couple of outliers on the good end at the bottom over here. And then on the top end, you have a number who are not doing so well with their performance with what they're showing. Here's just a different way of showing you the up and down relationship. Sorry. Now, what drives this performance? Well, I'm going to take you back from that buckshot picture to this and tell you that the most important thing is the fistula risk score. It's the most prominent influence. So for each point on the score, you're going up by an odds ratio of 1.5 for development of clinically relevant fistula. So it's the dominant factor, the risk that you're encountering. We can also look at this in terms of severity. So this PMI is the post-op morbidity index. It's a quantitative look at how your complications go, not just frequency. And what you can see here is the severity of your fistulas and your overall case is going to go up as the score goes from 0 to 10. We've also now been able to show that the score predicts mortality. And you can't do this unless you have a lot of patients and a lot of deaths. So we had to have the 5,000 cases together. But if you look across the zones here, you have a stepwise progression up to a high-risk case by the score. You have a 3 to 4% chance of dying because of that, because of the starting point. And interestingly, we've now just had this paper accepted in the last week that basically shows that this fistula risk aspect augments the American College of Surgeons mortality and morbidity prediction scale. This does not involve pancreas-specific factors. Okay, it's just about how your COPD is, your weight, your BMI, that kind of stuff. but it doesn't talk about the risk of being a pancreatic operation. And this augments it. So clearly this gland and what we're working on affects the outcome, and we can make prediction better by adding the fistula risk score on top of this. Here we are again. We can do the same thing that we did with frequency of fistulas with severity of fistulas. And you will see that some institutions manage a fistula situation better and have less severity than others, and the same goes for the surgeons as well. So let's get into these mitigation strategies. What can we do now that we're faced with this? Well, work we've done has actually countered some of at the same time, actually, the pasireotide trial came out that said, hey, this is good stuff, and it makes fistulas a better situation. However, we were able to bring together 1,200 cases, and if you put this together, it's more than all the randomized controlled trials put together on octreotide. And what we were able to see and use this risk score for is actually to risk stratify the cases. We know that a lot of these cases in real life and in the trials aren't risk stratified properly. We know that you're probably giving octreotide when you think you got risk. So this is sort of helping to balance that out. And what it shows is that when you give octreotide, you actually have a higher rate across the full spectrum of having a fistula, counterintuitively. This probably has to do with inherent wound healing issues and other issues of the drug, not just the exocrine dryness, exocrine insufficiency that it makes. So here you can see here, when you risk stratify this, the dark blue is when you don't give octreotide, and then the light blue, and you'll see the dark blue will go up across the risk zones. You'll have more fistulas in a high-risk situation. But when you're actually giving that octreotide, you're actually exponentially advancing the risk and making it worse. So I actually personally have dropped octreotide for 3 years now since we did this. The next thing we did is we looked at internal stents, and we actually found that these are bad things, and a lot of the literature has said it's either neutral or negative, but we found that there were complications. They certainly don't prevent fistulas or stop them. And you can actually even argue that they're bad things because they may even make fistulas or augment them in low-risk scenarios. So you don't need to be putting these in on every case, and they're probably not giving you value in the cases you think you're getting them. Let's talk about external stents, though, because they are more germane, and there's data to say that these are actually valuable. There's good randomized controlled data to suggest that. Well, we've been actually interested in, does that apply to every case? Do you need to put an external stent in a duct that's this big, a centimeter? Probably not. So later on in this meeting on Saturday, my research associate, Matt McMillan, will be presenting our work on this, where we actually show that you can actually whittle down who needs this stent and gets value from it. And it is, in fact, the high-risk scenario. So probably only 10% of your cases need this. Very interestingly, no single risk factor in the score shows value by having it. So if you say, oh, today I want to put in a stent in because there's a soft gland, that's not going to show you value by doing that. But when you put the cluster of risks together and you have a high-risk scenario, that will, in fact, show less rate. And here it is. You see across the risk, focus in on the high-risk zone on the right here, and you'll see that there's significantly fewer clinically relevant fistulas by a lot when you put the external stent in there. And the regression analysis substantiates that. Here's another interesting thing we found. Drain amylase, okay? The fistula risk score actually predicts your drain amylase the next day on day one. As you can see, it goes up there, and it also shows you where your amylase is in the clinically relevant fistula cases on the right. So you may even know this the day before you're measuring it at this point and have value by knowing this in the operating room. What about drains now? So you might have seen the talk earlier by Bill Fisher, and he explained the fact that we were able to take that Van Buren study, which is a randomized controlled trial, and reanalyze it with the score. And with that, we were able, because that study came out, was really focused on the overall morbidity and the mortality aspects, but really didn't whittle down on fistulas. And what we were able to find actually is that when you placed a drain in moderate and high risk cases, you got value from it. But if you placed a drain in a low or no risk case, which is about a quarter of all the cases, if not more, you actually had more fistulas in that group. I can't explain that to you. Why does this drain make a low risk situation have a fistula? I don't have that answer. But I know that I've seen it time and time again in the studies we've done. So we've therefore come on to a management algorithm that brings a lot of these concepts together. And that is, we would suggest that you, and this is in Journal of American College of Surgeons, what we did here is we took Claudio's original RCT that defined 5,000 cutoff and early drain removal as a paradigm. And we reanalyzed the data from that, and we said, well, what if we used the risk score in this and made an algorithm to do that? What would come of it? So we would suggest that you can be in the operating room, you can take your score and figure it out. If you're a negligible or low risk scenario, you can safely, from the data I've shown you here, say you don't need to put your drain. There's no need, no value, and you may even be harming yourself by doing it, okay? On the other hand, the other 3/4 of the patients have moderate and high risk. Put the drain in. Then you can go to the next level of doing drain amylase assessment and perhaps early drain removal. So if you're over 5,000, that's a high chance you're going to have a leak. It's 70%, 60%. Just leave the drain in, use your discretion, see where it goes. Also, obviously, if you have sinister effluent, as they say in the paper, leave it in because it's telling you something, all right? But if you're under that 5,000, you can follow the principles of that RCT and take out your drain earlier. So we remove drains on day 3 if they are appropriate by that amylase content. Now, we actually put this into practice in a prospective fashion. So I have a question mark here. Could we affect change by doing this? So Verona and Penn put our data together. Historically, we had a 21%, 20% clinically relevant fistula rate between the two institutions. There were 260 cases that we then prospectively followed, every single case that the two institutions did for a period of time, no exclusions to it. Of that, interestingly, 20% were high risk. That's double what I showed you for the rest of the world, and that's indicative of the fact that both of our institutions do a lot of cyst disease and maybe some less cancer than other things. So we had an enriched population here to start. So we did the low and negligible risk. That was a quarter of all the patients, and we didn't put drains in those at all. Lo and behold, without the drains, no fistulas. Didn't happen. So we now feel that we can really tell you what is the selection that, if you want to do selective drain management, you can do this by numbers now. So no fistulas happened. Now, the moderate and high risk group was 3/4 of the patients. If you were under 5,000 on your first day amylase, we removed the drains, and that led to only a 2% rate. Again, probably confirming the fact that early drain removal is very beneficial and good for you. So that was a very low rate. So you feel very confident. I can tell you, you see these amylase levels. Before we pulled them out on day 3, we had the day 3 amylase as well. They go boom, boom, boom. And you see that you're in the clear with this. However, there were 2 caveats here. We had this group of greater than 5,000, and Claudio's paper never randomized those patients because they're too risky, they were felt to be. So we left them in on the 5,000s, but we also had sort of a bailout aspect because this was not a randomized trial, and we knew the realities of trying to pull this off. So we allowed surgeon discretion into whether they would remove these earlier or even place the drains in the case. And there were about 20% of the whole series that basically got overridden, protocol violation if you want to call it a randomized trial. But this is important because if you had this discretion, it almost matched up completely well with if you had greater than 5,000. So we have a sense, we have an inner sense as surgeons when that fistula is going to happen, and it's pretty much borne out to the high-risk situation. To wrap it up on this, we actually, and here I have an exclamation point because I think something happened here, and I think, there's something going on about changing the practice that is real. We believe it. Claudio's group has come to come around and believe this. That's what he said. His residents are telling him, Dr. Vollmer's protocol says you must do this, and we believe it because it's actually showing results. So the new rate was half, basically half of that. Highly significant for clinically relevant. So this also led to lower percutaneous drain rates, lower hospital stay. Both institutions individually improved. There was an institution that had higher rates to start, they came down. There was an institution that had lower rates on that spectrum, and they came down significantly. Surgeon discretion matters. We did find that if you see bad effluent or you don't like what you see on those drains, keep it in. You're probably going to have a fistula, it's safe. And we also learned how we could decipher this greater than 5,000 high-risk group. So what does it mean to be in that group? How do you get to be a high 5,000, et cetera? We'll be able to show you that in the paper when it comes out. So I'd like to wrap up by just saying we have come a long way, baby. This is the most interesting man in the world. He, too, enjoys telling us that we've come a long way with this. And I would be letting you down if I didn't look into the future a little bit beyond here. So the next places we're taking this is we'd like to think that fistula can be just as much personalized medicine as chemotherapy application can be. So if you're able to take, we're going to use data, and we're going to use this huge data set of 5,000 cases. If you were to look at the fistula risk score, you could have 80 unique scenarios of those 4 risk factors put together. For example, I could say today we have a soft gland, we have 550 blood loss, 2 millimeter duct, and it was an ampullary cancer. Okay, well, what is that? Well, it's going to equate to a predicted pop rate of this, and in fact, we could tell you the burden of your fistula can be predicted in a numerical way as well. And then we hope, at least in the higher cohorts of how many we accrue here, that we could tell you what mitigation strategies might work best on that particular scenario. So we think there's a future with that. And finally, I think there's some evolving concepts that have to, that'll come about here. How much does it matter what we do? How technically adept are we at putting the sutures and making our anastomosis? There's fascinating stuff coming through about assessment of our skills. And Melissa Hoag presented this just last week in the American Surgical, how we can videotape surgeons and basically predict if a fistula will happen just by looking at their dexterity and aptitude. So I think that this could even be a great teaching mechanism and process improvement thing in the future. It's kind of like doing lap choles and realizing your bile duct injuries happened because you looked at the videos and you saw them happen, right? So maybe we'll be able to influence change there. The second big thing coming around is there a microbiome influence? Not so much in pancreas, but in colorectal and other intestinal anastomotic processes, there is very strong evidence that the bacteria in the bowel can be activated to be in a super aggressive bacteria that can actually eat tissue and make your fistulas. So it's quite possible that this could be in play for a crapped out anastomosis. I think we really need to hone in on how we do the hard ones. We'll have a paper coming out soon where we focus in just on these high-risk cases, and we're going to be able to say what works for that and what doesn't. And finally, I think that this will help us get together with better clinical trials. We now have a risk assessment tool. So it's not just as nebulous as it's a soft gland. It's actually a quantitative aspect that we can apply when we're stratifying our clinical trials. So with that, I'd like to finish and thank you for your attention. Thank you very much.